thank Dr. Ahmed. I think he approached me almost like a month ago, asking me for a small introduction about point of care ultrasound in emergency medicine, just like an introduction, giving the importance of emergency ultrasound, especially in the field, since it's one of the things that usually every emergency medicine, I think, program or any attending now graduating from any kind of program, either here or any training program, I think emergency or point of care ultrasound is one of the things that usually is required in all programs. First of all, we are lucky, Dr. Ahmed, to have Dr. Ahmed as emergency medicine consultant in Dr. Salman Al Habib Hospital, and he's the program director of training in emergency medicine في Saudi board in Dr. Salman Al Habib Al Khobar. We are really lucky to have him there. So, and giving us this kind of opportunity. Hopefully that this lecture, it's just like a talk, small talk about the importance of point of care in emergency medicine, and just like to open the windows for each one of you. If you are in doubt that using point of care ultrasound in emergency is not as important as doing any kind of other tests, especially in seeing any patients in emergency medicine. So let's start in the beginning. I'll talk about what's point of care ultrasound, some advantages, why we are having an point of care ultrasound in emergency, how the usually ultrasound works, some vocabulary about ultrasound, artifacts, what kind of artifacts which is acceptable or normal that we are seeing in our images, and some common cases that we are seeing in a daily basis actually in emergency departments. And we'll talk about just like one slide about the opportunities of fellowships in ultrasound, in emergency ultrasound or point of care ultrasound. First of all, as we all know that the best thing to evaluate any patient is to take a very good history and physical exam. But nowadays, usually history and physical exam is not enough reaching to either to a diagnosis or best disposition for those patients. So usually you are doing a lot of testing, either like EKGs, labs, also a lot of images that can be usually done for those patients. But when we reach to those kind of images, what are the best modalities that we have to choose between all these images in especially in the emergency setting? So before choosing any kind of images, so we should put in our mind that a lot of factors that can play a role but to choose in choosing like any kind of or any types of image. So before doing that, think about the usual emergency patients. They are stuck in the emergency department. It's very difficult to take them out of the emergency to do any kind of procedures, either like imaging or any kind of procedures, especially if they are sick. So we should think about portability of those kind of images, the safety of this image. We know a lot of things that usually pediatric patients, we are trying to avoid a lot, doing a lot of images, exposing a lot of pregnant ladies, maybe early pregnancy for some radiations. And if we are able to reproduce those kind of images, the dynamic of images, which is very important to be considered. Also, the price. Nowadays, I know like most of the places, يعني الحمد لله, we are taking most of the things that usually in government hospitals, maybe for free or we can pay like a little bit amount of money. But nowadays, most of the hospitals, they are charging some money. So we should put this in our mind. Lastly, wait. The image quality, which is very important. Is the screen is okay, Dr. Ahmed?
كويس خالص دكتور عبد الله.
So let's start with an X-ray. Considering X-ray about the portability, we know that it's a portable. We can order it at any time, but the safety definitely it's a bit downside, especially for some people doing it multiple times. It can be done, but the dynamic for that kind of image is not that much. So is it expensive? Maybe it's the one of the maybe let's consider it between this kind of image modality and the others. Maybe it's not that expensive, and the image quality, depending on the image that we are requested, we know that it's very good in for bone tissues, for example. We are diagnosing, for example, fractures. We are diagnosing, for example, some soft tissues like for pneumonias, but it's totally unhelpful for somebody who's having, or very less helpful for somebody who's having an abdominal pain, and we need to reach a diagnosis. Going for CT scan, it's definitely it's not portable. The safety, the amount of radiation is very high. Definitely, it's not reproducible and not dynamic. It's a bit expensive, and but the image quality is a little bit way better than the X-rays and other image modalities. Going to the MRIs, is it portable? No, it's not portable. Is it safe? Maybe it's one of the safest modalities, but there are definitely radiations with the MRI. Definitely, it's not reproducible or dynamic, and it is very expensive comparing to others. But the image quality, it's the best image quality that we are having. Moving to the ultrasound, nowadays, is it with the point of care ultrasound? Definitely, it's portable, and definitely, it's very safe. Definitely, it can be done multiple times without any problem. It is dynamic. Most of the point of care ultrasound, usually it's without any kind of price. I know some like countries right now, they are charging the point of care ultrasound with some little bit of cost, but comparing it to the comprehensive or official ultrasound, usually it's nothing. Image quality. Let's talk about for the last couple of years, most of the ultrasound machines, the image qualities are becoming way better than before. Comparing ultrasound right now with 20 years ago, definitely the image quality is becoming way better. So what's point of care? So what's point of care ultrasound? It's just like I want to keep it very simple. It's a focused, limited, bedside, and
عفوا دكتور عبد الله الصوت قطع.
um, Dr. Ahmed, and I think you muted me.
Yes, by mistake. I'm
That's
sorry.
that's fine. That's fine.
So sorry. استاذنكم دكاترة كله بس يتأكد ان هو ميوت. لأن بالخطأ دخلت عملت ميوت لحضرتك.
It's okay. As we say that performed usually this kind of point of care ultrasound, it's totally different than the comprehensive study that usually done in the radiology department. So usually this is performed in a clinical context. I have a question right now, and it's usually answered my questions immediately. So there are three components of usually doing an ultrasound images or performing an ultrasound images. Definitely image acquisition. And usually, this image acquisition usually it can be done by somebody who's doing the ultrasound, like an ultrasound tech or radiology tech. Image interpretation usually it can be done by a radiologist, and incorporation of finding into patient care. Usually, the one who's taking care of this patient. Remember that all these components or all these things, usually it's done by the same person, which is the point of care ultrasound physician, which is taking care of the patient at that time. So moving to doing a bigger question, if I'm having the capability of doing an ultrasound in the radiology department, why I'm doing it bedside. So what is the differences? Let's talk about the pathway or the road of ordering any kind of study that usually done by a radiologist or done in the radiology department. Usually, the emergency physician will order the scan. Then the tech will perform that. Then the radiology will read it, and the emergency physician will incorporate the results into the patient care. Do you think how long it's going to take to do all of these? In the best case scenario, let's talk about 1 hour at least. The drawback of this, usually time consuming and sometimes information loss. Okay, usually, or those kind of reports, usually if it's written in a paper and this paper is lost, you will lose those kind of informations. Sometimes you order like a scan for example, an abdominal scan looking for, let's say, a gallbladder stones or biliary tract, and this kind of scans done toward the left side or toward the lower abdomen can give you some information which is totally irrelevant to the patient complaint and can give you a very hard time managing this patient. But in point of care ultrasound, usually the MD, he is the tech and he is the radiologist. Usually to answer focused information. So I'm looking for a gallbladder stone, for example. I put the probe in. I'm looking for the stone, if the stones are there or not, if there is an inflammation or not, which is very important. So the benefits, there are many benefits. It's give you an immediate answer and can incorporate with clinical correlations with those patients in the emergency. So many benefits of doing point of care ultrasound. One of the things that can save your life. Somebody who's really sick cannot go to the radiology department. With your point of care ultrasound, actually you can put the probe in and you can save that patient immediately. The question that I'm always being asked by many like students or interns, this is usually for radiologists, why I'm doing this. So as we all know that for decades, usually who's doing the point of care ultrasound or doing the ultrasound bedside, usually the cardiologist and the OB. So it's actually, it was there. Somebody is using actually the ultrasound before the radiologist, or I'm not saying before the radiologist, but with the radiologist at the same time. So in 1999, the American Medical Association passed the resolution that ultrasound is within the scope of practice of all appropriately trained physicians. They did not mention about emergency physician. They are talking about any physician who's trained can use the point of care ultrasound. And in 2001, the American Institution of Ultrasound in Medicine created a section of emergency ultrasound. And now the emergency medicine physicians, they are the leaders of point of care ultrasound, either in education and research in this kind of field. So is it just like for emergency physicians? Are they the only one right now using just a point of care ultrasound? I don't think so. Now we are talking about many specialties, maybe all the specialties, they are using an ultrasound. I know that in US right now, usually the point of care ultrasound can be done in OPDs, in rheumatology clinics, in anesthesia clinics, even in ophtha clinics. Sometimes even they are used right now by the neurologists looking for some sound waves in the brain. So all the specialties right now, they are using the point of care ultrasound that can help them or guide them in treating those patients coming either to their OPDs, in their OR, or any other applications. So the questions that usually always asked are how the ultrasound works, or how usually this kind of images appear. Usually, ultrasound waves produced by the machines, usually those kind of sound waves, let's say very high frequency sound waves started from the machine. It goes to the transducer. From the transducer, go to the body of the body with different kind of tissues, and it bounces back. This kind of tissue, it could be bone, it could be soft tissue, it could be a solid organ, and it bounces back. How it represents or bounce back to the transducer according to the amount of sound wave that can be absorbed by that kind of tissue. So those kind of sound waves, usually it's inaudible. So usually a human being cannot hear that kind of sound waves. Okay, so if this can hit a bone, definitely it can reflect, the amount of reflection is totally different than if it's, for example, it's a liquid or a free fluid, or it's a soft tissue. Okay, so just a minute. No. So you will hear a lot of different like terms, vocabs that you are hearing while anyone doing an ultrasound. First of all, one of the things which is really important, which is the echogenicity. You will hear it a lot. Somebody who's saying that this is hypoechoic, this is hyperechoic, this is anechoic, or this is echogenic. So what's the difference? If this kind of reflection is very, very bright or very white, okay, like for example, bones or an edge of an organ, like in this kind of image, usually we are calling it more brighter. It's more like hyperechoic. If this kind of the same like tissue-like structure, solid, like for example, solid organs or livers or kidneys, this is going with more toward an echogenic. If this is going more toward bloody things or free fluid, this is more toward hypoechoic, or it can be anechoic, which is totally black. If you are working in emergency, I don't think that you'll see more than these three probes. The first one called like the curvilinear probe, or somebody's calling them like even the abdominal probe. The second one is called the phased array probe, or we call it even the cardiac probe. And the last one is the linear probe. What are the differences between each probe that you are seeing in front of you? So the first two probes are very low frequency probes, but usually these kind of probes are going with a very deep structures. The amount of frequency, usually it's up to like 5 megahertz, some probes up to 6 megahertz. So the quality of images, they are good, but not as good as the linear probe. If you are going with the linear probe, which is the straight probe that you are seeing down there, the frequency of it reaching up to 15 or even more megahertz. So the quality of images is very high. But the problem with the linear probe, it cannot go for deeper structure. So usually the curvilinear probe, which is, you can see it's curved, usually it's for deeper structures, and we use it mostly in the abdomen. The phased array probe, it's a small footprint. So we are usually using it for echocardiogram for the heart if we want to put the probe especially between the ribs. And it can actually be used in the abdomen if your curvilinear probe is not working. Linear probe, definitely this is used for superficial structures, for example, the eyes, the MSKs or musculoskeletal structures, even for putting some lines for procedures. This is very helpful. Okay. So when you are holding the probe, okay, there is something very important. We call it the probe marker. If you are holding this as a curvilinear probe, there is a small dot on the left side of the screen, okay? And it's the same dot that is in the probe marker or on the probe. We call this a probe marker. So why we are using or we are looking for the probe marker before I'm putting any kind of the probe on the body of the patients. Usually, I'll look for the probe marker. So what did this person did? He's applying the gel, and you can see the gel that actually started from this mark. So that's his probe marker is there. So why we are looking for probe marker? Definitely for the probe orientation. We have a lot of orientations that can be used, but in emergency setting, we are using either the sagittal, usually the probe marker toward the head of the patient, or in the transverse plane where the probe marker usually toward the right side of the patients. Try to put this in your mind. Definitely it can help you identifying your organs, looking for any adjacent structures, and definitely identifying the abnormalities there. You will hear a lot of things that is that can be used by radiologists or by point of care ultrasonographers, like sliding the probe, like taking the probe from one side to side, rocking the probe if you are following the probe, especially if you are doing some procedures or following the hollow structures, sweeping the probe up and down, or fanning the probe if you are targeting a specific structure and looking for an abnormality, compressing if you are looking for something deeper structure, especially if you are looking for example, something retroperitoneal, or looking for the aorta in the abdomen. And you need to compress, or you need to compress for an artery or vein or to find an abnormality. Rotating, we are usually rotating the probes specifically for or mainly for looking for an abnormality. Usually one plane usually is not just enough. If you find any kind of abnormality, do another plane. We are using it a lot, especially in echocardiogram. So that's how we are using fanning. We are fanning an organ, sweeping, going up and down with the same structures. Especially we are doing it if we are sweeping for looking for for example, abdominal aorta and looking for the vessels over there. Rocking, we are usually using rocking, especially if we are looking for hollow structures like veins or a structure that usually filled with a fluid, or during a procedure or procedure insertion, like for a needle or something like that. So if you are new in ultrasound, that's the first thing that I saw when I saw an ultrasound machine. I thought this is a very complicated thing to do. It looks like a cockpit in driving an airplane, or you are you want to be a professional, for example, photographer. So definitely it's not complicated. Things that you need to put in your mind are these written in the left side of the screen. So power, probe, depth, using the gain, freeze and save the images. So power, any machine, either it's an old or new machines, the power button will be very clear for you. Then choose your probe according to your applications or your your request for a kind of an ultrasound. So using from the beginning, you are doing an ultrasound for any kind of probe. Try to select that kind of a probe according to your application. Then the depth, which is very important. If you are seeing in the top of the screen, actually this is the heart. Okay. If you are doing, wait, it's not the video is not working. Okay, that's fine. So if you're looking down there, that's the actually the a person who's doing actually a triple A study or looking for abdominal aorta. For that scan in the right side, he's so close, so he want to increase the depth. So he want to get the vessels nearby and to do some measurements. So the depth is totally, you should know before using the ultrasound how to use the depth and how can you either increase it or decrease it. Gain, this is the what do we call the brightness of the image, either to increase it or decrease it if you are looking for describing an image for the echogenicity that is hyperechoic, hypoechoic, or anechoic accordingly. I advise each one of you try to save images, even especially if you are in a training like a place where usually you are seeing the images, documenting the images. Try to go and do it. Freeze, we use usually the freeze for measurements. If you are doing any kind of measurement, freeze the screen, it will be standard still and do your measurements and then save it. Most of the ultrasound machines, they are not saving just images, they are saving images and clips, which is usually the last 6 to 10 seconds. Lastly, before going to the cases, I'll talk a little bit about artifacts. A lot of artifacts we are seeing, and everyone is talking about it. Some of them are usually or normally is there, and some of them usually it's abnormal. I have to comment on them. So the first one is a shadowing. Okay, a shadow usually for an organ. Probably most of the shadowing that we are seeing, it's because of the bone or because of the stone. Like if you are seeing the video that is playing in the right upper screen, this is a gallbladder stones, which usually having a lot of gallbladder stones, big enough, causing a lot of acoustic shadow or acoustic shadow, that kind of black arrows behind the those kind of stones. We are calling this is an acoustic shadow. Then reverberation artifacts. Those kind of artifacts are usually produced by or occurs when there are these kind of sound waves bounce back or bounce repeatedly in usually the lungs, for example, or in a tissue that is actually moving, especially the lung. Those kind of bands between those kind of tissues will create highly reflective surfaces. Those kind of surfaces creating like false, equally like spaced, like hyperechoic bright lines. Those kind of lines, it could be something normal or it could be something abnormal. Like we are seeing in the top of the screen, the left side, we call this kind of A lines, and the right side of the screen, we call this as B lines or comet tails that can represent some fluid in the lungs. Third thing that is posterior enhancement. So for posterior enhancement, this kind of artifact, what we are seeing it, or usually we are seeing it when there is this kind of artifact, usually it's a brightness of the sound waves. This usually will be seen behind any structures that usually filled with a fluid. For example, it's a urinary bladder, or it's in the gallbladder, or any other kind of structure that usually filled with a fluid. Then edge artifact, which is something normal artifact that can usually produce when there is a sound waves coming from the machine, and it will hit the boundaries of a hollow structures. Like for example, down there, it's the eye globe. Usually, those kind of boundaries, which is usually when it hits that kind of boundaries, which is it will create some sort of an artifact. We can see it down there. This kind of artifact, this is normal artifact. You should not mess it with any kind of abnormal artifact. Mirror images, those kind of mirror images, it's very simple that it's what we call it a strong sound reflector. When usually a very strong reflector, like for example, the diaphragm, which is the most common strong reflector, it will act like a mirror. Those kind of sound waves, it will be redirected to another object by the transducer, creating almost like a duplicate image of that kind of tissues. For example, what we are seeing here is simply a mirror image of the liver that we are kind of seeing it just above the diaphragm, representing that it looks like two livers or just a liver below the diaphragm and above the diaphragm, that's the normal. But if you are seeing this kind of image just in the right, so the left side is the one that we are expecting. So this is the right upper quadrant. But in the right side, what you are seeing in the right side, you're seeing a free fluid. So there is no mirror imaging of the liver above the diaphragm, which can represent this is abnormal and can represent a free fluid in the pleural space. So lastly, I'm usually trying to end with this, that I'll present some cases, which is usually what we are seeing in a daily basis in our emergency departments. And the ultrasound or point of care ultrasound is playing a very big role in those kind of studies. For example, let's start with this case, which is a 24-year-old male patient coming with an MVA with severe abdominal pain, and he's tachycardic and hypotensive. You grab the ultrasound for a fast scan, and you saw this. So what you are seeing here is the right upper quadrant ultrasound, which shows that the free fluid in the medicine pouch or hepatorenal pouch, which can represent, it's almost like hypoechoic or anechoic fluid, which can represent this is a free fluid. So this patient probably need the proper resuscitation and can be taken to OR immediately. If this patient is unstable, usually those patients will never be taken to or unstable to be taken to CT scan. So this patient should be treated immediately by taking them to OR. This is the scan in the right side, which is a normal scan for the same application. So this is the use of a fast scan for those patients that can help you in managing those patients. So let's go for another case. So this one is a 44-year-old female coming with a shortness of breath, chest pain in the right side, and the heart rate is 125, and her baby is a bit low. You did the ultrasound for her lungs, and you saw this. So what do you see here? It's very simple. Hopefully that most of you saw this kind of presentations. So this is no sliding for the pleura in this lady. So this could be representing a pneumothorax. If this patient is unstable, definitely you need to intervene immediately and put a chest tube for her. That's how it looks like, the sliding for a normal pleura for any other patient. So this patient is having a pneumothorax. So an 18-year-old male stabbed in the chest with a butcher knife. This patient coming to you, he's having severe chest pain and shortness of breath. You put the probe in, and you saw this. So that's a cardiac scan. You saw a significant free fluid with some sort, and he's unfortunately he's hypotensive. This patient is having a large pericardial effusion that can represent with a tamponade with tamponade features. So that's how it looks like in a normal patient who's not having any kind of pericardial effusion. So the management for this patient, if this patient is stable enough to be taken to OR, or you should perform a pericardial census and prepare this patient to OR. So moving to another case. 82 years old with past medical history of acute MI, diabetes, present with shortness of breath, altered mental status, and she's hypotensive. So this patient is in shock. We need to know what's going on with this patient. You put the probe in and you look for the heart, or is the heart is working properly or not. It's very obvious that the patient is having a very low ejection fraction. So you can initiate immediately the management for this patient with pressors that can help them help the lady to becoming better. So this patient is having a cardiogenic shock. That usually can be done immediately with a simple putting the probe on those patients. Moving to another case, a 67 years old smoker patient, actually present with abdominal pain, with a BB of very low, which is 80/50, and he's tachycardic. This patient is shocky. You don't know what's going on. You put the probe in, and what you saw over there is the aorta. The aorta actually is very huge. We are talking about almost 8 centimeters, and there is a hematoma in it, and this patient is suspected to have an abdominal aortic rupture. That's how it looks like in normal patients. Usually it's not more than 3 cm, but for this patient, it's almost like 8 cm. So this patient is having abdominal aortic aneurysm with possibility of rupture. So another lady, 40 years old, MVA, BB is very low. She's tachycardic and she's tachypneic. You did the FAST scan as usual, and you saw this. This is the left upper quadrant. And what is there, which is very obvious, is that the patient is having free fluid above the diaphragm, which can represent a hemothorax for this patient. You should put a chest tube immediately and start resuscitating this patient with the blood and to prepare her if she needs an OR. Okay, so 50-year-old with right upper quadrant abdominal pain, nausea and vomiting. You put your probe in immediately while you are examining the patient. You saw this. This patient is having what? Multiple gallstones in the bladder without any signs of cholecystitis. So you call it this patient is having biliary or gallstones. This patient can be managed maybe like medically, and he should follow in the clinic if all other parameters are good. So another lady with a male patient who's having a leg pain, edema. This is a very frequent scenario. He's flying from, he just flew from Riyadh or from New York to Riyadh 3 days ago. And you did the scan for his lower limb looking for a possibility of DVT. And this is what you saw. It's that kind of femoral vein, which is non-compressible, and there is an echogenic structures inside it, which can represent that this patient is having a DVT. So this is the normal usual scan for any patient who's not having a DVT. Usually the compressibility, it's all the femoral vein is totally compressible. Moving to this case, 42-year-old male coming with dyspnea, history of major hip replacements almost like a week ago. This patient was discharged 5 days ago, and he's not taking any kind of medications at home. So when he came in, this patient was having severe shortness of breath and dyspnea. You put the probe in. This is the parasternal short view in the upper images. You saw that this is the RV looking over there. It's very huge and pushing the left ventricle. You apply the apical 4. You're looking for the right ventricle. It's very huge. And this patient is having probably a pulmonary embolism or that might need immediate treatment by either giving anticoagulation or possible thrombolytics if this patient is unstable. That's how it looks like with the normal patients. That's the parasternal short view and the apical for a normal patient who's having not having a possibility of pulmonary embolism. So moving to this case, which is very common that we are seeing it in, especially in pediatrics, somebody who's coming with abdominal pain, you don't know what's going on, and during your exam you saw like there is a tenderness in the right lower quadrant. We know that we are not preferring to go for a CT scan for this patient, and you tried to go for an ultrasound, and unfortunately they told you about it will take like at least 2-3 hours to do an ultrasound or comprehensive ultrasound. You put the probe in, and you saw that this patient is having an appendicitis, which is very typical, blind-ended loop with all signs of appendicitis in this patient. So you call the surgeon, this patient can be taken to OR immediately if all the setup are ready. Okay, so moving to this case, lady, known, which is very common. Known heart failure, known COPD, coming with a shortness of breath, tachypneic, hypoxic, and wheezy bilaterally. And always the question, is this patient coming with acute decompensated heart failure or acute COPD exacerbation? So what you should do, I think the ultrasound can give you a very big hint. So you put the probe in, looking for any possibility of B lines, and you saw this patient is having coalescent B lines, many B lines in the pleura. So you can call it, and you can treat this patient as acute heart failure or acute decompensated heart failure, and you can start the management properly. Okay, so one of the frequent dilemma that we are having in our emergency, somebody who's a bit sick, maybe septic shock, for example, a very difficult line, for example, because of the anatomy, because of the small veins, or you want to start any pressors, and there is no IV access or very, very small IV access, definitely need a central line. So definitely ultrasound right now is the standard of care for any central line insertion. So it can help you while you are doing an ultrasound. So ultrasound right now is the way to go for any kind of procedures usually done in emergency, especially central line. So lastly, I'll talk about fellowship opportunities, which is usually asked for this. As far as I know, that fellowship opportunities probably it's more in North America, usually in Canada, and some centers in US. Those kind of fellowships, it's not just like going there doing the hands-on. No, it's doing like the hands-on training, reviewing a lot of images, a lot of lectures in a weekly basis. You'll go with the research, a lot of research activities. You will educate people, you'll educate students, interns, like residents. You'll do a lot of courses. So that's how usually the fellowship or the زمالة في المناطق هذه usually it will be run. في السعودية or in Saudi Arabia, some centers now starting the fellowship في السعودية, وإن شاء الله hopefully by next year or the year after it will be إن شاء الله in our university hospital. Will start as standalone fellowship إن شاء الله in emergency medicine or in emergency ultrasound. Hopefully by 2026 or 2027, after finishing all the administrative things, hopefully we will accept some fellows, inshallah. So most of the centers in North America accepting graduates with local boards, regardless your background, either it's an Saudi board, Egyptian board, Arab board, any kind of board they are accepting. So before ending this, just remember that ultrasound is great for ruling in or ruling out pathology, but you must know which kind of applications you are using. Don't put the probe if you don't know what you are doing. Remember that there is no risk to putting a probe on a patient, but there is risk in making decisions based on your ultrasound. So this patient either you can direct the whole management or the whole process for those kind of patients in the emergency. Either they will get admitted or they will be discharged according to your point of care ultrasound. So just take home points. Remember that ultrasound is a risk-free machine. So do it. Usually, I'm asking usually the interns, resident to do the ultrasound. Usually, I repeat it once, twice, maybe three times, especially if those patients are unstable. Do it without any kind of risk, especially if we are talking about risk of radiation. Think of opportunities to use ultrasound when you see patients. As I remember my program director saying that no patient's coming to the emergency and he's unscannable. Every patient can be scanned, whether he's having a very mild complaint or a very big complaint. So any patients can be scanned in emergency. Practice whenever you are already getting a confirmatory study. If you, for example, know that this patient did a CT scan and he got, for example, an intestinal obstruction or an appendicitis, you can go and grab your ultrasound and do the ultrasound looking for the abnormality. It can help you a lot. Remember, thing which is very important, it's save time. It is really save time and it save radiation. It's helping especially those patients who's having a problem with high radiation or risk of radiation. It saves a lot of money, especially if those patients they cannot pay for a confirmatory study or a comprehensive studies. And the most important thing, which is it can save life. Thank you very much. Any questions? I'll open the floor for Dr. Hadidi.
ألف شكر دكتور عبد الله. الصراحة كانت يعني مش عايز أقول لك محاضرة عظيمة. I enjoyed الطريقة اللي حضرتك بتحاول تبدأ بيها كل حاجة وتبدأ البيزس بتاعت الالترا ساوند في وقت قليل. عملت كومبريشن لكورس كامل في ساعة. فأنا عارف المجهود اللي حضرتك عملته. وأتمنى إن أنت توعدنا إن شاء الله يبقى في محاضرة تانية، يعني محاضرات تانية مش بس المرة دي بس.
بإذن الله بإذن الله، ما يعني إن شاء الله معاك إن شاء الله يا دكتور أحمد. إن شاء الله we'll have إن شاء الله courses إن شاء الله either hands on، ونتشرف بالجميع إن شاء الله. I'm always preferring usually giving lectures about ultrasound is good، لكن في نفس الوقت it's very difficult to apply. Even if I'm explaining for example a lecture about doing fast scan, giving the lectures it's totally different than the hands-on. Hopefully that we will ما شاء الله يمكن almost 100 participants attended this lecture. Hopefully that all the 100 that can come and we can do a full day of hands-on course إن شاء الله يعني بوجودكم وبإشرافكم يا دكتور أحمد.
ان شاء الله ان شاء الله احنا بنشكر حضرتك. طبعا زي ما حضرتك بتقول كده الهاندز اون دي اهم، يعني او اهم ان الناس لازم تبراكتس الحاجات اللي شافتها دلوقتي واتعلمتها. بنستأذن حضرتك دكتور عبد الله ان المحاضرة المتسجلة ديت ان احنا ننزلها للدكاترة
ولا يهمك.
على اليوتيوب.
أكيد.
نشكر حضرتك جدا. وحضرتك كمان حطيت الايميل.
This is my email. Please contact me at any time. I'll be happy to reply inshallah يعني within time very short time frame inshallah. وأي سؤال for the emergency for point of care ultrasound, either references, either fellowship opportunities, please don't hesitate. This is my email. Anytime يا دكتور أحمد، وفي الخدمة في أي وقت.
ألف ألف شكر دكتور عبد الله، ألف شكر.
بسم.
شكرا لحضرتك دكاترة، ونشوف حضرتك إن شاء الله دكتور عبد الله في محاضرات قادمة إن شاء الله زي ما وعدتنا.
بإذن الله بإذن
إن
الله.
شاء الله.
شكرا
السلام
دكتور.
عليكم.